this hospital since we opened 7 years ago. And we've been giving these talks on knee replacement for several years now. I appreciate you all coming out. I wanted to give you some brief information about myself. I've been in practice out here in Northwest Houston for almost 19 years. A significant part of my practice is knee surgery, probably about 70%. The other thing I do a lot of is shoulder surgery. There have been a lot of exciting advancements. I see a patient of mine in the back that's had both, actually. So there have been, in my opinion, a lot of exciting advancements in knee replacement surgery over the last 4 or 5 years, and I'd like to share some of those advancements with you. So we'll start. I've titled this talk Patient-Specific Partial and Total Knee Replacement. I think one of the most exciting things that have happened, or that has happened in total knee replacement technology in the past several years, has been customizing the implantation of total knees to a patient. Years ago, when these things first started getting developed and implanted in the 1970s, there were several sizes available. Not always did they fit well. That's been refined over the years. But what's been gaining popularity and acceptance over the past 3 to 5 years in particular is customizing the implantation technique to the patient. And so I want to share some of that technology with you, what's being developed and what we're using here at this hospital. So just a brief outline of this talk. After this brief introduction, we'll talk about causes of knee pain, treatment options, which always include no surgery as an option, options, of course, that include surgery. We'll have some conclusions and then plenty of time for questions. This talk tends to run about 30 minutes, so there'll be plenty of times for Q&A at the end. So we'll start by talking about types of arthritis. You know, the most common type of arthritis by far is what's called osteoarthritis, which is the wear and tear type of arthritis that most people are familiar with. If your grandmother or grandfather had arthritis, more than likely they had osteoarthritis. That's something that tends to run in families and tends to occur more frequently with age. There's also post-traumatic arthritis. If you've been unlucky enough to have had an accident in the past and broken your knee or torn a ligament and may or may not have had surgery to repair that, years down the road that can develop arthritis as well, which is independent of your DNA, but completely dependent on your prior injury and surgery history. We have different types of inflammatory arthritis, like rheumatoid arthritis and lupus. Those things can strike at any age and can tend to be very rapidly progressive and sometimes very devastating. The medical treatment of these types of arthritis has gotten very good over the past decade or so, and so we see less and less of those types of knees coming to surgery, but still that happens fairly commonly. And then finally we have what's called crystalline arthropathy, where different chemicals in your bloodstream can precipitate out in the joint fluid that surrounds your knee and cause arthritis. The most common type of that is gout, that I think most of you have heard of, or a variant of that called pseudo-gout. So those are all the common types. Osteoarthritis, I think, by far and away is the most common, probably 80%, 85% of what I see in my office on a day-to-day basis. So what exactly is arthritis? We throw this term out all the time, but we never really talk about what it is. A normal knee, any joint for that matter, has cartilage that covers the joint surfaces, and that cartilage is typically very smooth, almost like glass, and so it allows the joint to slide easily when you move it. So when you move your knee back and forth, there's a gliding motion that occurs without any catching or binding or any pain. When you develop arthritis, what that actually means is you develop loss of that cartilage or damage or deterioration of that cartilage, so that normally smooth surface becomes somewhat roughened and irregular. So now you can imagine, instead of having two smooth surfaces gliding across one another when you bend your knee, you have something that looks like the picture on the right-hand side of the screen, which are these divots or these cracks in the cartilage, which hang up when they glide against one another and expose nerves that should not be exposed, and leads to pain and stiffness and difficulty with everyday activities, such as just walking to the car or walking to the kitchen. These are some pictures I took from some of the surgery that I do. I do not only knee replacement surgery, I do a lot of arthroscopic surgery. And so the picture on the left is a normal knee, and I think that if you look at this, you can see the very, very smooth, completely white, homogeneous appearance of the cartilage above and below the joint, and the nice little cartilage spacer or the meniscus in between. And contrast that to the picture on the right-hand side of the screen. You can see all these little pock marks or divots and these little fronds of cartilage hanging off. So you can imagine how this knee would probably feel pretty good when it moves back and forth, but this knee would not. And this is what an arthritic knee looks like early on before the cartilage is completely lost. We have lots of treatment options for arthritis. You know, if you've ever been to your doctor complaining of knee pain or ever been diagnosed with arthritis, you've probably been told at one point or another to exercise and lose weight. It applies to a lot of us. And that's sometimes easier said than done. We prescribe anti-inflammatory medications, and there are lots of those available. Advil or Aleve or Motrin are the ones that are available over the counter. We also have prescription medications, things that you may have seen advertised on television or in magazines, like Celebrex is a very common one, Relafin, Mobic, those types of medications. Medications work well to a certain extent. They take away some of the inflammation and they take away some of the pain. Any medication, of course, has side effects, and a lot of people already take enough pills as it is and would rather not take more pills if they can avoid it. So that's one option we use in mild cases, but it's not always successful. As a second line of therapy, when medications aren't an option or when people have tried them and they fail, we try different types of injections. There's a variety of these medications that are commercially available. They're called viscosupplements, which basically is just like a gel or a lubricant for the knee. One that we use commonly is this medication in the lower right-hand corner called Synvisc. And it looks like water, but it's got the consistency more or less of a thick motor oil. And what we can do is numb up the knee in the office and inject this medication. And it serves as a lubricant, so those roughened, irregular surfaces slide and move more freely and more naturally. It works very well. It's covered by most insurances, including Medicare. But the downside is that it tends to wear off relatively quickly. I mean, most people can get about 4 to 6 months of relief from these medications. After that, the results start to decline. So we use these very commonly when people have pain but aren't quite ready to pull the trigger on surgery or just need to get through something important coming up in their life, like a wedding or some sort of important social event. So these are valuable to us as well.